So they've been our patients for a long time. We're treating these things. We're modulating their immune system. We're pressing on those infections. We're detoxing the patients. Then they come out of hiding. They come out of the quarantine, finally ready to, they get COVID. Some of them, maybe they get the vaccine, and they do just fine. Our patients were absolutely fine. But what I noticed more is that the patients who came to us, who were not our patients pre-pandemic, they didn't know why they were sick. So of course we made our diagnoses, and what we found was actually what was reflected in a lot of the research now, that there are dormant infections in people, and those infections get stirred from spike protein and from a flare of inflammatory cytokines. When they get stirred, they then rise to the top and the patient gets symptomatic. So it's not just that they had COVID and COVID caused inflammation in the body. That is correct, but also other infections that were dormant came to the surface. Right, welcome everyone. We're just so happy that you're here with us today. So this is our pre-summit webinar, and the summit is just so important just because it envelops our life's work around patients with complex chronic illness. And maybe you're here today because you're suffering from long haul, or maybe you're a patient of ours. Welcome. We're just so happy that you've joined us. This is supposed to be a small summit. It's supposed to be just a 3-day summit with 20 speakers, and well, it turned out to be a 7-day summit with 50 speakers because there's so much rich information here, information that is difficult to find elsewhere. So we wanted to bring this to the surface.
Yeah, and I'm saying most importantly, but probably it's just information and people understanding what these post-infectious illnesses are like and what to do about them. You know, right away when COVID hit, within the first few months, it was clear there were reports of people who weren't having full recovery. They had persistent symptoms. Some of them started to develop new symptoms months after they had recovered from COVID. And, you know, this has happened, obviously, throughout history. We have these post-viral problems that have, in America and all over the world, been labeled anything from chronic fatigue to ME/CFS, and lots of other names. Post-Lyme syndrome can have some of the same issues. And this is not understood by conventional medicine at all. Even today, when the NIH is spending time and money looking at this, they're still thinking that it either has to be a persistent virus, chronic, some tissue damage, or perhaps some immune problem. Well, it's an immune problem. I mean, the other issues can happen. Yes, there can be persistent virus or persistent spike protein triggering immune damage, or immune activation, I should say. But the organ damage is not usually there. Can be there, but for most people, it's not. And that is why the medical community doesn't pay attention to these illnesses. And during the webinars, I'm doing a little bit today, but especially during the summit, we're going to be just emphasizing all the various ways the immune system is affecting your body and producing different symptoms, which when you're the person with the symptom, it's pretty obvious. But when you go to the doctor and the tests that are designed to find tissue damage are absent, it becomes quite a question of whether you're even sick. So we're going to go through this and during today, we're going to hit these points kind of over and over again, because I think it's really, really important. Just remember that conventional medicine, which is basically what we get, is trained on acute illness, where if you're really sick, they expect to see some damage at the level that their tests can recognize. Chronic illness is a more subtle event, and it's based on chronic inflammation. And our regular tests that doctors use miss chronic inflammation most of the time, unless you happen to have an elevated C-reactive protein or a SED rate. I don't want to go into the weeds there, but if those are normal, doctors are finished. So we have a lot to share especially over next week. And just right now, Nafysa, tell us a little bit about what is long COVID.
Right. So I'm going to link it back to the wastebasket diagnoses that have been given to a lot of our patients. In fact, almost all of our patients, they come in with diagnoses like fibromyalgia, chronic fatigue syndrome, or post-Lyme, chronic Lyme. And those are diagnoses where most doctors or the medical community has said, I don't know, we don't know what that is. So let's put this label on you, let's hang this label on you, and here's maybe some prednisone, and here's an antidepressant, you can go home. That's it. So a lot of these patients have been also told, this is all in your head, or just pull yourself up by your bootstraps. If only you'd work a little bit harder, then you could get over this. What's wrong with you? Then a lot of the patients start to think there is something wrong with them, right? Psychologically, I've heard many patients tell me, am I losing my mind? Am I actually crazy? Am I making this up? I started to ask myself, do I want to be sick? So this mindset in medicine, and then the response from the patient, I see this in long haul as well, because patients who have long haul have very similar mysterious symptoms as patients with the wastebasket diagnosis. So those symptoms, the similar symptoms are brain fog, post-exertional malaise, joint pain, gut issues, hormonal issues, mood changes, sleep disturbances. And so back to what is long haul, it is a combination usually of most of these symptoms. That's what I'm finding with my patients. Some people might have a couple of them, but most people who come to us have all of these symptoms. And it's at least 4 weeks after having COVID. We've also seen a lot of vaccine injury. We won't deny that. So really, it's a lot about spike protein and the inflammation that that's causing. And so that is long haul. Oh, one thing is that you could have COVID, maybe 4, 6 weeks, a few months later, get some symptoms. They resolve, but then several months later, they return. And so we're having a lot of people come to us with these symptoms, and they don't know why at all, and they're not linking it back to spike protein.
Yeah.
They don't know.
And one of the things that I know that Dr. Parpia, really brought to my attention early on was how important it was to do deep dives on people's histories, because that's she was finding these hints that all was not well before people developed long COVID, because many of our patients thought they were fine. But when we started to look closer, tell us what we really started to notice that right off.
Right. Well, I noticed two things. We both noticed this, that our patients who were our patients pre-pandemic, of course, they had all the diagnoses we had made, right? That most of them have a combination of tick-borne diseases, high viral loads, for example, Epstein-Barr virus, HHV6, cytomegalovirus, many different herpes viruses. Often they have parasites, mold exposures. On top of that, they have environmental toxicity. So bugs and toxins. Now, because of that combination, they get immune dysregulation, a hyperactive immune system and a weak immune system at the same time. So hyperactive meaning they've got mast cell activation syndrome, weak meaning they're not able to mount an appropriate immune response to kill the infections that they have. So they've been our patients for a long time. We're treating these things, we're modulating their immune system, we're pressing on those infections, we're detoxing the patients. Then they come out of hiding, they come out of the quarantine, finally ready to, they get COVID. Some of them, maybe they get the vaccine, and they do just fine. Our patients were absolutely fine. But what I noticed more is that the patients who came to us, who were not our patients pre-pandemic, they didn't know why they were sick. So of course we made our diagnoses, and what we found was actually what was reflected in a lot of the research now that there are dormant infections in people, and those infections get stirred from spike protein and from a flare of inflammatory cytokines. When they get stirred, they then rise to the top and the patient gets symptomatic. So it's not just that they had COVID and COVID caused inflammation in the body. That is correct, but also other infections that were dormant came to the surface. So we have people who are suddenly in chronic Lyme. They didn't even know they had Lyme before.
Yeah, and this issue of immune dysregulation is, I think, probably the most important thing in chronic illness, because in my worldview, chronic illness is chronic inflammation. It just means that your body is designed to deal with something that's really threatening to you, and we live in a world of bugs. I mean, we coexist, we co-evolved with all these bugs, and especially the fungi, and they shouldn't make us sick by and large. But often when our immune system is overamped, and it's like, the brakes aren't working, or they work intermittently, you get a lot of lurching and a lot of attacking of things that you don't need to attack. But when your body defends itself against an infection, it makes you ill. I mean, that's just what happens. Those same chemicals that are designed to get the bug to contain or destroy a virus or a bacteria, those same chemicals make you sick. That's what causes fevers and the desire to just lie down in the corner and not interact with other people, loss of appetite, headaches. It's all inflammatory chemicals. So, but you can have all of that and still have normal organ function and even normal blood counts and normal gross levels of the immune system, because what your doctor measures for immune function is merely looking at the number of neutrophils and lymphocytes, and a little look at something called monocytes, which are the macrophages, but there's not many of them floating around in the bloodstream. They're called monocytes when they're in the blood, and macrophages when they go into the tissue. But the point is, they're looking at a very small part of the immune system, and they're looking at a very gross measurement, okay? Because in those lymphocyte subfractions, there are, we don't know how many subsets of lymphocytes they are. I mean, there are, it's if you follow the immunology literature, you quickly realize that this is, the field changes week by week. So the idea that your doctor sits back and says, your immune system is fine because your blood count is fine is absurd. If you're having symptoms of inflammation, we have to look deeper. Now, in this conference, we're going to talk to a lot of people who have looked deeper from different angles. One of the people who early on I thought was really helpful, he got he's gotten a lot of flack.
I jump in with a couple of questions before you.
Sure, please do.
There.
Yeah.
Just because there's some great questions here, and I want to talk about. I know where you're going with the people. This is great. Okay. Maria had a question. I contracted COVID a little over 2 years ago and still have not regained full sense of smelling taste. And it's been very strange experience. Only, and maybe the last several months has it started coming back, but still altered or not gained back with different things like onions, eggs, etc. Anything terribly pungent. As well as certain aromas that aren't pleasant, like lavender. I'm hoping to gain some insight and a sense of hope after watching this session and the summit.
Well, we know what we'll tell you what we know. The hope is that it does tend to get better. And there are some people with some ideas of how to treat this, because there seems to be at least two issues here. One, the initial loss of smell seems to be not so much nerve damage, but the supporting tissues of the nerves in the nose and the olfactory bulb, in the nose part still before it gets into your brain, the supportive tissues are injured by COVID. The nerves aren't directly injured in the beginning. So, but usually those tissues come back. But that's something to talk to, if you can find an enlightened ENT to take a look and see how healthy those are. And then there's the neural issue of whether, there is persistent spike protein that's keeping inflammation going locally, because that is what so anyway, so there is hope. And I think we do touch upon this in some of the talks on neurologic things. We have it, and I think looking in that direction for there's some medications and supplements. Unfortunately, we can't practice medicine on webinars.
But there's ways to bring inflammation down in the sinuses, and I think that plays a role here. And I wonder if maybe there is some chronic sinusitis. I'm seeing that a lot in my patients, and they don't even know they have it until they say, "Oh yeah, I'm clearing my throat a lot," or, "Oh yeah, I'm coughing a little bit more," or when they press, there's a little bit of pressure. Doesn't have to be a big thing, or they have headaches, or they have brain fog along with it, or what you have, this sense of smell that's not returning. So we can do a test to look for what infections might still be present. So if there are other infections in the sinuses, they're also creating inflammation that can cross the blood-brain barrier via the olfactory nerve. So there are ways to treat the bugs in the sinuses and to bring inflammation down in the sinuses, and ways to bring inflammation down that has crossed the blood-brain barrier.
Yeah. And just to emphasize here is, once again, is that the damage may have happened and be gone, and then secondary issues keep inflammation going that doesn't let healing happen completely, because inflammation is your body's first response to the damage. You have to get to the healing phase. And this is where, again, paying attention to what Dr. Parpia said, and also some of her talks on peptides can may be helpful. And some of, I said, the talks on the brain of lowering inflammation in the brain, because a lot of this, it can be at the nose level and it can be at the central nervous system level. So, but you have to look and explore and know that the average doctor, unfortunately, isn't going to have a clue, because the things that we just spoke about are not things they believe yet. And I'm going to wait till the end before I give them my little spiel about why doctors don't believe these things.
I love it. I'm going to ask one more question here, and then we'll hop back into taking a look a little bit more at who's in this summit. One question here from Fallon: post-COVID, I have a lot of anxiety, not worried thoughts, more of a physiological response with a pounding heartbeat, nervousness, being easily startled, and not being able to think straight, shakiness when I wake up, and not being able to handle stress at all. What is the best way to manage this?
Well, there's lots of ways into that one. I'll say two things, and I'll let Dr. Parpia say a few things. But this is an autonomic dysfunction, that reflects inflammation, probably in your brain, but doesn't mean you have an infection in the brain. The inflammation in the brain can come from anywhere in the body. Okay,
so that can cross the blood-brain barrier from the gut, from the sinuses, really from anywhere.
Absolutely. Yeah. And so understand that. But sometimes, this is where regular doctors actually, at least the CDC has helped set up, and the NIH, some centers of excellence where they have people with long COVID see, cardiologists, pulmonologists, rheumatologists, neurologists, the whole ologist field. And out of all that, most of the time it's useless. But when you have autonomic issues, especially the rapid heart rate, they can sometimes give you medications that will quiet that down enough that can sometimes change the danger signal to your body. And so your body can then begin to shut off more inflammation, because this is the circle that people, I keep saying people don't understand, because I say people don't understand because we're frustrated all the time when we try to communicate, not with our patients so much, but with other physicians, that the body is a circle. There's nothing that's psychological and nothing that's just physiologic. It's a circle. When your brain, when you start sensing your heart racing, you get anxious. Doesn't matter, like as you're experiencing, nothing to do with your thinking. It's just the limbic system has gotten turned on. So sometimes, yes, you can do things that actually relax your brain that will help this. So there's multiple things, but as Dr. Parpia was saying, is also look for where the persistent inflammation is, because something somewhere is probably making some organ not feel safe. And that's whether from your gut, or maybe it's just the heart. When it starts beating fast, that tells your brain danger. The heart's fine, but it's the autonomic nervous system that's a little inflamed. So I hope that wasn't too long, but just there are things to do, but you got to find the right people to work with. And that's what we're doing this talk, because we're talking to a lot of smart people. And if you follow them and their links, you're going to find lots of doctors who can help.
Right. And so some of you might be our patients, but you're from another state. If that's the case, we can't write you a pharmaceutical prescription in that state. We want you to have a primary care physician over there or another doctor over there who can write you a prescription. I'm coming to the camera again. I'm thinking of medications to help you with POTS. And so I can recommend them to you, and you can see if your doctor there would write that prescription for you. And I'm also thinking about how COVID can wreak havoc in the microbiome, right? There's research on that. In fact, research is now coming out that there can be some reservoirs of COVID in our gut still. We're not able to test for that yet there's no test available to us, to doctors yet, but the researchers are finding that. So back to the gut-brain connection, it's huge. So testing your gut is important because there's that highway of nerves from the gut to the brain. Inflammation travels up and down. It includes the vagus nerve, includes your autonomic nervous system. So from the gut to the brain and all the way in between, right? All those can be inflammation, and all those nerves can be causing what you're describing. So we need to work on bringing inflammation down in your nervous system and autonomic nervous system regulation, and possibly some pharmaceuticals, which
And your favorite, peptides.
my favorite, yes. I've just seen so much magic happen with my patients with peptides. Most of my patients can tolerate them, but
and just a note about peptides is that they are what your body makes in the healing process. They're the breakdown products of these big enzymes that your body makes when there's first tissue threat or damage, and then they break those big things down into these smaller molecules we call peptides. And so we're just feeding the information that your body seems to be missing, and sometimes it picks up the conversation at the right place and quiets down the inflammation. Because remember, inflammation, we keep talking inflammation. It is something that should happen and stop. I always compare it to anger. Being angry in a moment is very healthy. Staying angry is very bad for you and everyone around you. And it's the same thing with inflammation. If you don't turn on inflammation hard and strong, you're going to get really sick when you get exposed to COVID or anything else. But if you can't modulate that and turn it down fairly quickly, you're going to, that's how people die from COVID, is because their own inflammatory process gets hijacked and is way on too high. And we get long COVID because our inflammatory process is not turned off completely in some parts of the body. And that's the other important thing. It doesn't have to be throughout your whole system. As we said, if it's in your gut, it can be in your liver, it can be in your kidney, but they create chemicals that kind of signal there's something wrong throughout the whole system. And your brain is very sensitive to that. So anyway, go on to the next things.
yeah. So I want to talk about how medicine in general looks for a one-size-fits-all treatment. And just like they have been for chronic fatigue syndrome, fibromyalgia, Lyme disease, mold, all these wastebasket term diagnoses. So medicine looks for one lab, one diagnostic, one symptom, one treatment. And all of those should be the same across the board, across humanity, right? Now, that's applying the acute model of illness on top of chronic care, which just doesn't work. So we all behave similarly when we have a broken bone, even heart attacks, or even say acute pneumococcal pneumonia. These are acute illnesses, the body hasn't started to have enough inflammation to cause genes to express. So we humans will act pretty similarly in the face of an acute illness. So then we can give one diagnostic, one lab, one treatment in those cases. But our patients, including those with long haul, it's gone way past that. It's become a very personalized process. So now we're talking about inflammatory cytokines meeting your genes. And so that's why there's not just one treatment for long haul or just one treatment for any of the illnesses you or your loved ones might be suffering. I'm assuming you're watching this because you have some connection to complex chronic illness. So now it's an individual expression. What you're going to find on the summit is that there are many different ways to address this. Eric, do you want to talk a little bit more about that, or
Well,
about the New Republic article?
oh, well, actually, what I'm going to throw in something that I'm very sensitive to in this whole area, because we're talking about individualized medicine, hopefully in the best sense of it. And people are now calling it personalized medicine, but anyway, but also there's personalized medicine, and then there's quackery. And we are often, to be honest, for 40, well, Jonathan Wright once very proudly said, "I am a quack." Jonathan Wright was a very old physician in those days. It was the alternative medicine field, and but anyway, because we are willing to treat the individual before we have the double-blind placebo-controlled study. And I'm going to try to keep this to 2 minutes, but the medicine has gone down a wrong path. There's something called evidence-based medicine, which was developed, I believe, in the 80s and 90s. It was started. It was really, drums were beating, and it's a great concept. Okay, it's about looking at the individual and looking at the data. Okay, the evidence, looking at the trials, looking at what information we can get, and going back and seeing how that fits the individual. Now, so that's where it's rich. Unfortunately, because medicine has become overtaken by accountants, no offense to accountants, but we focused on just the double-blind placebo-controlled study and not the individual. Okay, and the problem with the double-blind placebo-controlled study is severalfold. Number one, they're incredibly expensive to do. We're talking $10 to $100 million to just do simple stuff. And two, they're designed to remove probably the most potent healing force we have, which is the placebo effect. And placebo effect is not this thing that should be avoided. It's harnessing our will and our intention to heal. It's, people have used it as though it's a phony. Again, it's snake oil if it uses the placebo effect. Well, we heal because we want to, because we believe we can.
I want to stop for 1 second. There are a lot of people out there who want to heal, but they still can't.
Oh.
Okay, so we're talking about this connection between your will and understanding the terrain of your body. So you might want to heal and you're trying to will it, but it's not happening. It's because the will hasn't been met yet with personalized medicine, and this does take some time, right? Usually when our patients come to us, it's I tell them, it's like you've come to me as a ferry ship, right? It's a big ship. It takes a long time to turn a big ship. Maybe if it would come when it was a kayak, we could turn that around really quickly, right? So it takes some time, in the combination of will and time, working with a really good naturopathic or functional medicine doctor who knows how to understand your biochemistry and genetic expression.
Yeah, no, and I just wanted to say, when I'm talking about the will, I'm not, God, I mean, most of my patients have far more will and drive than I do. It's not the sufficient, just because you want to get well doesn't mean you're going to necessarily get well. I always remark on so anyway, some of the great saints in all traditions who died very painfully from diseases. So but it's a piece. And the double-blind placebo-controlled study is designed to kind of remove that from, and that's okay. And we should do that if I'm going to give you something that is life-threatening. If this is a chemotherapy drug that if I give you a little bit too much, or even if I give you the right dose, you might die from it. Well, then I want to be sure that I'm not counting on anything but the drug working. Okay, but 98% of the things that I offer and most people who are in this field offer are not going to harm you. Okay, they can make you feel bad for a day or even a week if you're super sensitive, but by and large, they're not going to harm you in any long. They're not going to kill you. So I don't think we need that same level of evidence. And so that's where we're going to talk to one of the people that we talk to is Dr. Michael Peloso, who is a researcher from the University of San Francisco, who just a fellow who had been in the AIDS world, treating AIDS for years. And he realized as soon as COVID started, he wanted to start collecting blood from them. He had no idea that long COVID was going to happen, but this was a different virus. So he started collecting blood in April of 2020. And then he started noticing as he was collecting blood in late April and June, that people who had been sick for 2 or 3 weeks in March and April were still not feeling well. And so he was really early on to recognizing that something is happening here. But so this is
We're talking about the speakers now.
yeah. So but the issue that we have from the government is that though they're beginning to wake up and trying to do large studies, they're still hung up on treatments across populations. And that's why so many things have failed in the world of ME/CFS, because it's subsets of people. ME/CFS, just like long COVID, is not one illness. It is the body's expression that looks alike, meaning the symptoms, but you get there for different reasons.
I'd say it's multiple illnesses at once. It's multi-systemic illnesses. It's different in each person. But I've been told it's time to start discussing our speakers because we're half an hour in already. We want to leave some time for questions. So thank you, Darcy. She just texted me.
Okay.
So
Okay.
you probably have more questions after hearing all of this, and we're going to save time to answer all of those. So now, long haul and COVID required different detox protocols. This is an important thing to understand. So those of you who are my patients, I've probably put you on a detox protocol that's very personalized. I've tested your labs. He has too, right? With his patients, tested the labs, looked for environmental toxicants, and you've heard me say to you personally, or you've heard me say on other summits, that environmental toxins cause immune dysregulation. There's a lot of research on that. So it's important when somebody is suffering from a complex chronic illness to look at environmental toxins and to understand if they are contributing to immune dysregulation. So we have a speaker, Dr. Lynn Patterson, who I will say is, sorry, Lynn Patrick, I was mixing up with Bruce Patterson. I merged your names. Dr. Lynn Patrick, she is a very important person, doctor and researcher in the field of environmental medicine. And in fact, environmental medicine wouldn't be what it is today were it not for Dr. Lynn Patrick. So if you're here today, thank you for everything you've done for this field, Dr. Patrick. Now,
I'm going to share my screen, Dr. Parpia, so that people can see as well, just so you know.
Okay, thank you. And so she speaks about environmental toxins and immune dysregulation and how that can play an effect in long haul. Now, there's that type of detoxification that can happen. The other thing is that we need to detox spike protein. That's different than detoxifying environmental toxins. There needs to be a double-pronged approach. Detoxing your environmental toxins if you've got a high load of them, and also finding ways to get rid of the spike protein. So I have a talk with Dr. JP Salibi where he discusses that, and Dr. Gordon speaks with Dr. Mubin Syed, well known as Dr. Bean, about this topic as well. So we're talking about detox from many different angles, and I think you'll find that very interesting.
And, and going back to the immunology of all this, Dr. Bruce Patterson is someone I speak to, and Dr. Patterson is one of those people who right now he's trying to do his best to be to follow the scientific method and rules. Unfortunately, he broke one of them where he actually started offering his tests to patients before conventional medicine would say it was ready for prime time. Except, when in my discussions with Dr. Peluso, when we talk about the government's approaches, you'll realize is that nobody's thinking that they're going to have anything to offer people for 2 or 3 years at best. And when I'm sitting with a patient, that's just not good enough. We're going to have to do things that maybe are not perfectly baked. For some reason, the government was willing to release, vaccines after a very, 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 very quick review. So I think it's fine that we do the same with things that are much safer. So Dr. Patterson has a test, not a perfect test, but we have found it useful in also seeing some differences between long COVID and people with ME/CFS, and helping us adjust therapies, but also making it very clear of how sick people are on the biochemical immunologic level. And then I've had the real pleasure to talk to Dr. Pierre Corey, and Dr. Corey it was a leading doctor in the world of intensive care medicine. He's written textbooks, he's lectured everywhere. He was one of the young leaders, and he started with, when he started seeing COVID, because he had been involved in research with moderate doses of intravenous vitamin C and sepsis in the ICU, he started using that. He also was one of the first people to really push the use of steroids during the second and third week of COVID, and especially in ICU patients, which was the biggest life-saving change that we had in treating COVID in the first year. For hospitalized patients. What got Pierre into our camp of the world, into our camp, was he also thought that ivermectin was a good idea. And he testified in front of Congress about this early on, and he has continued to accumulate data and research and exposed some of the shortcomings of the mainstream research. So Dr. Pierre Corey is no longer in the hospital, but he's out there on the front lines, teaching doctors all over, him and Dr. Paul Marek and many others in what they call the FLCC. And they have a very reasonable program of things people can do to stay healthy. And some of these same therapies do help people recover. And one last thing I just want to say, Dr. Bean, I really urge all of you, listen to Dr. Bean podcast.
That's Dr. Mobeen.
Dr. Mobeen Saeed. Okay, his show is called Dr. Bean. He's a medical educator. Okay, and he is someone who will help guide you through the morass of the claims and counterclaims, because there is, little politics here. COVID vaccines are not the best thing in the world, and they're not the devil. They cause a lot of people problems, but they have helped a bunch of people. I mean, it's not black and white. And we interview many people who do think it's black and white. So be prepared for that. There'll be boosters on both sides of this discussion. I think the science is in the middle, and Dr. Bean does a very good job of really leading you through the papers about this line by line, because both sides, unfortunately, are using this broad brush approach to kind of cover up the inconsistencies in their arguments. Anyway, so please have an open mind. It's not as clear cut as either side in the media would have you believe. So that's my 2 cents on the politics of this unfortunate situation, or the unfortunate politics.
We'll hear from Dr. Paul Anderson. He was a mentor of mine, and he has spearheaded IV therapies in naturopathic medicine, and he has changed the way modern naturopathic medicine is being practiced today. He was a big proponent of IV vitamin C in the hospital setting and in private clinics for patients when they had COVID, and he gathered a lot of the research on that and presented it to people. He's going to talk about co-infections, the infections that were dormant that now present once COVID has gone. So it's a fascinating conversation that I have with him, and everything he talks about is exactly precisely what we've been seeing with our patients. So it's just wonderful to hear other doctors speak about what we're seeing and to see it now show up in the research. In fact, that's a big deal, because finally what we've been seeing for decades in practicing, well, him for decades, me for 12 years, practicing complex chronic illness, is it's actually showing in the research as correct. Immunology is catching up. Looking at concurrent infections is catching up. Still, there are a lot of deniers, and maybe this is a good time to talk about that article that was released last night, unless there's some other speaker you want to talk about.
Well, I think just mention you interviewed Dr. Vaughn, and he goes a lot into the issues of microclots, and Dr. Pretorius's research from South Africa, and I think that's really important, again, because people get here for lots of different reasons, and I think he's got something very important there. And I talked to Dr. Tanya Dempsey. Dr. Dempsey, her partner, her work partner is Dr. Larry Afrin, and he is the man who really put mast cell activation on the map. And working with Dr. Dempsey, Dr. Afrin has learned a lot about how important infectious triggers are for mast cell activation. And Dr. Dempsey and I talk a lot about that. And then we have Dr. Dale Bredesen, well known for his work in cognitive issues and dementias, and Dr. Suzanne Gazda, who is a neurologist who also does a lot of work with any obviously neurologic issues and the various cognitive problems that people are having post-COVID. And it's not just cognitive, please. When we're talking about the brain, it's also the mood and emotional things that and sleep that are happening to people. And I want to emphasize over and over again is that when you have the right genetics and a certain amount of inflammation, you're going to have mood disorders. You're going to be either anxious, maybe even OCD, depressed, or some people can get manic. It just depends on how you're wired, but it's inflammation which drives these things. And this is actually where psychiatry is going today. The biological psychiatrists are realizing that their stories about the neurotransmitters are just stories and haven't held up. And it's inflammation that's driving the show. And then you got to talk to Dr. Smith, and
that's a great conversation. Dr. Smith is a fantastic neurologic chiropractor. He's also a dear friend of ours. Now, one thing that was brought up, full disclosure. So one thing that was brought up is the immune system. Well, that's brought up almost in every conversation, but very specifically the immune system, and how many times functional medicine doctors are talking about stimulating the immune system. Now, a lot of the times our patients their immune systems are stimulated in the wrong direction. They've got autoimmune conditions, they've got mast cell activation syndrome. That's a hyperactive immune system. So then you start to stimulate that and things can go haywire. So it's not just, we want to stimulate the immune system, but it's more like we want to retrain the immune system. We're looking to modulate it. So that was discussed. But the main thing that he works with is patterning in the brain and how that is connected to inflammation. So that's a gem of a talk, I think, because not too many people, it's not in too many people's wheelhouse to understand the effects on very particular parts of the brain with respect to inflammation.
Yeah, hugely important, because one of the things that we were talking about last night, an article, we came across a newly released article. I forget the gentleman. Do you remember the gentleman's name who wrote it? I mean, it was a really
Ryan Pryor.
Ryan Pryor, who's coming out with a book on long COVID as well, but he had an article, and he referenced an article in the New Republic by the science writer who I think was Natalie Shure, and he was pretty upset about what she was writing, and there were, I understand that when I started to look, that there were multiple responses in Twitter and in the media about, because she was writing about long COVID as possibly being what they're calling a functional neurologic disorder. And when doctors say functional, they don't mean to be insulting, but it kind of comes off that way. What they're saying is that there's no tissue damage. Okay, this is like irritable bowel syndrome, when people have like alternating constipation and diarrhea. They often call that a functional bowel disorder, because when they look on a colonoscopy and they do those little biopsies, they don't find tissue damage in most people with irritable bowel. If it gets severe, it becomes inflammatory bowel disease. At that point, they can see changes on the biopsies. But until they see changes on the biopsy, it's considered a functional disorder. Now, to be fair, but they and what's reinforced this is things like antidepressants at low doses actually help many of these things. But it's not because people are depressed. It's because these medications interact with our immune systems, both peripherally and in the central nervous system. Anyway. So this idea that long COVID is another one, and just like ME/CFS in England has long been considered a functional neurologic disorder, meaning that if we just teach people to relax and do some graded exercise and cognitive behavioral therapy, they're going to get better. Now, this has been debunked as being a overwhelmingly successful therapy. There's a little bit of benefit, but it's so tiny, it's clear that this is not the cause of the illness. So to just get to the point here, is that these things that they are calling functional are just because they're not looking deep enough into the system. And the kind of work that the neurologic chiropractors do, looking at these habitual reflexes that are set up, begin to show us where we can see changes. Now, if you look with a neuroquant specialized MRI imaging, QEEGs, we can find changes in the brain to show that these are not just superficial. They're deep changes. It's just that we don't have well-established tests that the average doctor looks at, so they call them functional. Anyway, the point I'm trying to make is that we have to get past this. It's biologic, okay? There's chemicals that are causing these things, and your mood, as much as we can control it, can help. But you don't get sick because you're depressed. You do get depressed when you're sick. And the same thing with anxiety. So you'll hear me rant about this many times throughout the summit, and you'll get a lot of support from some of these leading thinkers in how the nervous system and the body interact.
Thank you. So we did produce a citations guide, meaning there's just so much research out there on all of these things now. And that's the silver lining. That's the blessing behind all of this. The research is now starting to come to the surface. And so Darcy will pop that link up on the screen. And Darcy, do you have the link to the article by Ryan Pryor? Because that
Yes, I will put that in here as well.
That article, it discusses the naysayers, or the people who are saying that the research isn't real, or the people who are gaslighting this sudden boom in ME/CFS patients, really the boom in long haul patients. All of a sudden, these people who've had, we call it rare conditions, they would come into droves to our clinic for a long time, but now even more so after this pandemic, it does have to do with long haul COVID. There is research. We're providing that to you, and we're providing you with the article so that you can see what's being said about how maybe this isn't true.
And just to remind you again, The problem with research is that it takes 3 to 10 years, sometimes 20, until really great research ideas ever reach conventional medicine. Okay, and it's not from any conspiracy, it's just how the system to protect you has evolved to actually get in the way of your healing. Okay, so we have a lot of people that are interviewed that have ideas that will help you. And unfortunately, no, they are not FDA approved, but they work and they won't hurt. Well, I should say,
Great.
it won't hurt badly. I never want to promise things won't hurt because, my God, I've seen people react to everything. So I have great respect for the individuality, but there's a difference between reacting to something and being permanently
You can
damaged.
react to anything. You can react to any medication that your doctor gives you. Come back into the
Yeah,
screen.
yeah.
So, of course, many of you may have been given antidepressants and you reacted poorly to those, right? Those are FDA approved. So, we're just talking. We're talking about things that are gentle and that they pertain specifically to the individual. I want to circle it back to that because it is an illness that is individualistic, just like chronic Lyme, chronic fatigue syndrome, fibromyalgia. So now we add long haul to this bucket of misdiagnosed illnesses or wastebasket terms, but we're here to help you. And a lot of the doctors that we've interviewed are also here to help you. So thank you. I think we can open up to questions.
Yeah, I added, Dr. Parpia, the link in the chat to download the over 150 citations from the speakers. And then also the link is in there, everyone, to the article that Eric was referencing. So next, here's a great question. What do you suggest to take or do right after being sick with COVID to keep long haul away?
Well, I think we can't give medical advice here, but if you go to the FLCCC website, there's some great information on there. And I think that's the best we can do with respect to answering your question broadly. It's going to be individual though, because of course, if you come into our clinic, we're going to want to know what kind of underlying inflammation you have and what's causing it and treat that.
But the FLCC is a good place to start, and a lot of it is simple. I mean, that's the thing is that, the vitamin D, low doses of selenium, the vitamin C, magnesium, they sound so like, oh, who cares? But what we saw over and over again when we spoke to doctors all over the country, who many of them have practices like we do, it was the same thing. Patients who we were all really worried were going to do terrible with COVID did fine, because even though we didn't have them all better, the stuff they were taking, which includes these simple things, the basic vitamins, kept their immune systems at least from overstepping, and they actually did well with COVID. And we've seen almost no long COVID, which again is a shock. I would have expected, my already sick people to go there quickly. So
and they just didn't.
And it wasn't just us, because if it was just me, I'd say, I don't have, that many patients that I'm seeing, but I do. All of them. It was just very surprising. And there are some on the FLCC site. They will talk a little bit about ivermectin, and I'll leave that to your discretion. Because it's at low doses. People have reported that to be one of the many things that will, that may mitigate progression to long COVID. Again, I don't think the evidence is overwhelming, because who's collecting the data, unfortunately. But that's been the impression of people. So I think, again, the FLCC website will give you some real good insight and things to do that are mostly things that you can do on your own. You don't need a doctor to do if you keep to the simple suggestions.
Next question from Caroline. My primary long COVID vaccine-induced symptom is fatigue. with very minor other symptoms that are not problematic. I have not found others with a similar situation as mine. Have you treated any long haul patients who are primarily fatigued?
Of course, all the time. Now, I have two things to say to that. So one reason you might not have found other people who have similar symptoms to yours is because it's now expressing at your individuality, right? So it could be that inflammation has crossed the blood-brain barrier and it's affecting the sleep centers of your brain. It could have to do with your thyroid. It could have to do with viruses, could have to do with your adrenals, could have to do with your sex hormones. So all of these need to be measured. The expression of you at all of these levels is going to be different than the expression of the other person or the other people you spoke with long haul. And now, because we see so many different patients, we do see similarities in symptoms. So, I mean, what you're describing actually it sounds a lot like it could be chronic fatigue syndrome or ME/CFS. So yes, we've been treating patients like this prior to the pandemic, and now, of course, after the pandemic as well.
But I would say that but if it's predominantly just fatigue, and it's not, and the question I asked, if it's not muscle fatigue, if it's just that you get tired after you do things, but you don't have, what we call the thing that makes, in my mind, what makes it the ME/CFS world is if you overdo today and you feel terrible tomorrow. But again, the ME/CFS is more than fatigue. It's usually malaise and just kind of a sick feeling.
There's brain
So
fog and
yeah, there's a lot. So if it's just fatigue, and I think that's the point that she was emphasizing, that she's surprised that that's the only symptom she has.
let's find out, was it just that? Is it just fatigue? Because when I have a patient who comes to me and they tell me it's just this, I do a thorough intake and I find out, oh no, there's a lot more other symptoms that the patient has normalized, but it's there, so let's see what she says. Is it just fatigue or are there other symptoms?
Well, we can wait until she hops in here and we can.
Yeah, we'll move
Okay,
on.
sounds
Yeah.
good.
Yeah, a few people were asking about the FLCCC, and the reason you couldn't find it is, Eric, you were leaving off a C. It's FLCCC. It's
Three C's. That's
three
right.
Cs.
I'm
So
sorry.
I just put the link in the chat.
Fine.
So
Thank
yeah, some questions around chronic pain and tissue damage. What is considered tissue damage? In chronic pain derived from a poorly healed injury, there's no tissue damage. And if that pain goes down with anti-inflammatory drugs and rest, doesn't that mean that tissue damage has been reactivated?
We see tissue damage. That's the great question. I mean, generally, people would say tissue damage is when, if they did a biopsy, the cells weren't normal, or there was a lot of fibrosis there afterwards. But when you have chronic pain after an injury, what you have is chronic inflammation. Now, in time, if the inflammation persists, like if it's in a joint, you can get bone, you'll get remodeling of cartilage, you'll lose cartilage. And so, yes, you can change the tissue in time. And that's what happens. That's when you go from just my joint aches to an official diagnosis of osteoarthritis. But lots of times, it's just that the area doesn't get great blood flow. So nothing's broken there. And if you don't use it too much, you do fine. If you overuse it and you produce lots of chemicals, but if the muscles around it are tight or the connective tissue is tight, you don't get good drainage. And so then you have problems with not getting rid of the toxic chemicals that are created by the exertion. So you'll feel lousy for the day after because there's no drainage. And then, the non-steroidals are just rest. They'll get better. So this is a very fuzzy area until it's not, like you can have good examples with the heart. You can have angina. Angina is when the blood flow to the heart is limited, but it's limited for a very short period of time. And when it comes back, there's no cells that die. When you have a heart attack, you have that same limitation, except it lasted long enough that cells have died. And so that's kind of a gross level. And so you can have angina for years and not have dead cells. So, and that's why it can be missed, because your EKG can look normal, though you're having a problem with your heart. I'm sorry. I hope did that make sense to the question?
I'm sure we'll get a yes.
I don't know.
We have time for just a couple more. Here's another one. What do you suggest to take or do for brain fog? Also, you mentioned that sometimes people will find after COVID and then a few months later that they get symptoms again. Have you noticed if these people were vaccinated or not, or both?
Well, both, unfortunately. Like I say, there are issues with the vaccines that I don't think has been widely enough accepted. They're not free, in the sense that they gave them away, but they have dangers. And in some people, I said there's been over 1 billion. My God, over 1 billion doses probably given in America alone. So. And everybody's not dying, but a lot of people are getting sick, and so we have to take that into account. But both of them are the same. Just my point is that the vaccine and COVID both have spike protein. Spike protein is just one of those things that's incredibly immunogenic, meaning it stimulates your immune system to react. The immune system reacting is what causes symptoms, and which symptoms you get depend on how your immune system is put together. If you have, that's your genetics and how well you can turn off that immune system. So that's your immune system and your previous experiences in the environment that determines whether you're going to get flared by the second time exposure to COVID or not.
So we are right at the top of the hour, so I'm going to ask one more question here, which seems to be sort of an overarching gut microbiome. So how does COVID disturb the gut microbiome? Where's the best place to start when treating the gut when it comes to long haul?
Okay, that's a big question. Now, just like any pathogenic infection in the gut, they cause inflammation. That inflammation can cross the blood-brain barrier. It can cross actually any part of the body, can get to the joints. It's coming out that it's very possible that there is still COVID in the gut, right? And there's more research that needs to come out on its effects in the guts, but we do know that it causes inflammation, and perhaps it can crowd out the beneficial bacteria, just like any other pathogen can as well.
Yeah. Well, what I was going to say is, I interviewed Dr. Khazan. She's a gastroenterologist and an expert in actually in fecal transplants. But her feeling is that the amount of bifidobacteria you have in your gut can help determine how sick you get with COVID. In her research, she has found that that the bifidobacteria actually can absorb or adsorb. It can a virus, and as well as being anti-inflammatory in other ways. So bifido replacement is probably a reasonable place to start, but unfortunately, the gut, occasionally those things work. We tend to see people who've done that and failed, but I also know that there are lots of people who just try probiotics and actually do better. It just depends on how long you've been, how disrupted your gut is. We tend to see people who the simple things don't work in, but that doesn't mean you shouldn't try them first.
Right, and then I'm also thinking about microclots. So one thing we know is that COVID, a spike protein itself, can cause microclots. We're not talking about big clots that'll cause a pulmonary embolism, but small clots. And Dr. Jordan Vaughn discussed this. And in autopsies, so these are people who have died, they found microclots in the vessels that around the GI system. So now, I'm wondering if you are already inflamed in your gut, you already have dysbiosis, or you already have a high parasite load, or you already have funguses. Most of our patients, they have all of that. Then you get microclots in there from spike protein. That's another way that can be exacerbated. So someone asked about how that's treated. That's a long question, a long answer. It requires a long answer, but I would start with techniques to help remove spike protein as best as we can. Not that I can even measure it. I wish I wish we could, but there's no labs yet.
Well, we
that,
can measure the spike
in
protein
the gut. I'm
in
talking
the
about.
gut, right? In monocytes, and again, the lab is not. Probably there was some controversy about it, but we have found it to be somewhat useful.
Right,
Yeah.
right. So basically, general. How do I answer this? It's such a big answer, but basically, generally treating your gut as it's presenting. What infections do you have there? How inflamed is it? What does your beneficial bacteria species look like? Addressing all of that. What does your diet look like? Of course.
But
Yeah.
hopefully you're healthier and you're going to get away with just trying some probiotics. And because this is what happens is that we tend, our practice is usually people who've been ill for a very long time, and so we have to remember that many people, the beauty of the body, they just need a little bit of help and they go back to normal. And that's my prayer for all of you who are listening, that 1 or 2 tips and you're gonna begin to move that ship back to just being healthy again.
Right. Maybe you don't need us, right? Maybe you watch the summit. I really urge you all to watch the summit. Maybe you watch the summit and you speak to your naturopathic or functional medicine doctor, and you give them some suggestions from what you've seen. And maybe you are a doctor watching this and you want to watch the summit just to bolster your practice. And then something works.
Yeah.
You know?
What I love about doing the summits is how much I learn. Okay. Every time we talk to people who do things in depth, that you just learn more. And so that's what this is, an offering, the chance to learn and open your mind to ideas and see what fits. So thank you.
I have one more. I think we could wrap this up with this one comment. You guys are rolling your eyes because we are over time, but I do want to say Susan said, thank you so much for not giving up on us. I'm so grateful.
Oh,
Yeah.
thank you. We never will.
Yeah, because the study of illness is the study of health, and we're all working on that together.
Yes, it's our life's work. So we'll never give up. Yeah.
Thank you all. Thank you all so much for your attention, and hope you enjoy the summit as much as we did making it.
Yes.